And Joy over there, the nurse clinician, is incredible and part of the family as well. And I'm going to hand the floor over to you.
Great. Thank you, Dawn. Hi, everybody. Who are you all? Are you mostly parents?
Yes.
Are you mostly parents?
Yes.
Okay. Expectant parents, already delivered parents, all of the above?
Everyone here has already delivered. We have
Okay.
no expectant parents here today.
Okay. So I want you to interrupt me if you have questions. I want this to be very relaxed. And if you have a question, shout it out. I appreciate what Don said. If you've got a question about your child, I know enough on how to deal with those that I'm happy to hear your concerns. We can talk afterwards or any of that. And I'm going to do my best to help you walk through kind of what we've done. And I titled this, Diaphragmatic Hernia, Their Amazing Potential, These Kids with CDH. We've undersold these kids for too long. They can do so much better than what the general medical community thinks, and it's changing. People are going to start coming on board. But across the country, we see the whole spectrum of, oh, your baby's going to die, your baby's going to be brain damaged, it's not good, we need to terminate. And we're trying to move that forward to get people to realize how spectacularly well the majority of these kids can do. It's still difficult. It requires very refined, very experienced care, but it's about their potential. They have amazing potential.
It's not, yeah, you'll just have to use the arrow keys.
I can do that. It makes it harder to walk around. So this is one of our CDH kids that came from California. All right, disclosures. All patients and parents have signed meeting consents. So I'm going to show you pictures of kids. The parents all know it and have signed off on it. I was at the University of Florida in Gainesville for 23 years, and in that time I had the privilege to take care of 325 consecutive patients. I'm now faculty at Johns Hopkins. I have the privilege of working at the Johns Hopkins All Children's Hospital. How cool to be a full-time faculty member at Johns Hopkins and get to work in this cool children's hospital in Florida. It's really awesome. I've been there, really I came on about January 1st. Between January 1st and June 30th, we took care of about 35 patients, give or take one or two. I didn't get the count exactly right. So when I talk about diaphragmatic hernia kids, I want you to know I'm talking from a database of 360 kids. Okay? I have no financial relationships and no other things to disclose. Here is our Johns Hopkins All Children's Hospital. It's a 275-bed children's hospital in St. Petersburg, Florida. This sign has changed because we are now a full-time Johns Hopkins hospital. Okay, what are we going to talk about? Number one, I want to honor you as parents and the road you've been on and the road you have ahead of you. We support progress. We support everybody's progress in diaphragmatic hernia. We're all working together on this disease. But significant controversies exist about how to take care of these kids. And we're going to tell you our story. And I'm going to tell you right up front what we believe and why we believe it. And it may be a little contrary to what you've learned. My goal is not to in any way undermine your confidence in your doctor. But it makes no sense for me to come here and not tell you what we've done and what we believe and why. So please keep that in mind. This is a moving target. But I honor you and I honor your physicians and the people that have taken care of your babies. All right. So what have we learned after 360 diaphragmatic hernia kids? We've learned that there are principles of care that should be followed if we're going to get the highest potential out of these kids. I'm going to show you data, I'm going to show you outcomes, I'm going to talk about the importance of community in this disease, and we're going to talk about a little bit future progress. Now, this is really central. Diaphragmatic hernia is important, and it's important for many reasons. Obviously because of the disease, and it's important, but some people think this is just a little orphan disease. 1,500 kids a year. I mean, how important can that be? Well, it's terribly important, but it's also important at a much bigger level, because as we learn to take care of these sickest kids in the NICU, and mark my words, they are generally the sickest kids in the NICU. If we can get great at taking care of them, we can take care of all the other babies better. So this is much bigger than just diaphragmatic hernia. Now, in 2014, there were roughly 4 million births. There were 800 with gastroschisis or gastroschisis, depending on how you say it, and fewer than 100 will die. That's when the babies are born with their intestines outside their body. I might talk for hours. What time am I supposed to stop?
I'll give you an hour. How's that?
Perfect. All right. 500 will develop Wilms tumor, and fewer of those will die. But 1,300, 1,500 fetuses, nobody knows exactly the number. I had a parent write to me and say, Dr. Kays, you are full of you-know-what, because everybody knows the incidence of diaphragmatic hernia is 1 in 2,500, not 1 in 3,500. The truth is we don't know. These are all estimates, but that puts us in the ballpark. So using that estimate, maybe 1,300 fetuses will have diaphragmatic hernia, maybe 1,500, but half of them are going to die at least. Many are going to be terminated. We don't know how many that is. And then of the ones that are delivered, the survival at interested centers is about 70%. The survival at uninterested centers is probably less than that. The overall survival is surely 50% or greater when you add in the terminations. So it's a frequently lethal birth defect. If these slides are objectionable to anybody, I'm sorry, but we're going to see pictures of babies' insides. This is a baby that didn't survive. The baby had a very severe left diaphragmatic hernia. We pulled all the stuff out, and that's the remaining lung on that side. But importantly, look where the heart is. The heart is pushed so far over to the other side that there's very little lung left on the right side as well. This is a disease that affects both sides, not just the side of the defect. And there's a lot of talk. So that's pulmonary hypoplasia, lungs that are too small. There's a lot of talk about pulmonary hypertension. Have you all had your doctors talk to you about pulmonary hypertension? You've all heard of it, right? Well, I'm hopefully going to refocus the conversation about this, because although the kids do have pulmonary hypertension, it really should not be the focus of our care. The focus of our care should be on lungs that are too small. If we take care of lungs that are too small, guess what? The pulmonary hypertension tends to get better over time. If you focus on pulmonary hypertension, then you miss the opportunity to take care of lungs that are too small. And I think this dialogue is going to change. We have a major publication coming out in the next few months that will hopefully reshape the dialogue. If not, we'll. But don't get me wrong, the pulmonary hypertension is important. It's very important, but there are two components of the pulmonary hypertension. There's a reactive pulmonary hypertension that occurs in the first few days, happens in every baby, whether they have diaphragmatic hernia or not. Then there's a long-term pulmonary hypertension that is related to lungs being too small. And what do we want to do with lungs that are too small? Help them be as big as they can be. All right, what is current diaphragmatic hernia survival? Here's a population-based study out of Canada, which was 54% survival. And here is survival from the diaphragmatic hernia study group, published in 2009. I think this has been updated to 70%. But it's basically what I told you before, somewhere in that range. Now, you all know this, but just to make sure we're reading from the same hymnal, diaphragmatic hernia is a spectrum of disease, from less severe over here to insanely severe over here. And babies are in all these places along there. And how do we look at the severity? We can look at it by how much stuff is in the chest. So that's an anatomic look. It's very helpful. The big key in looking at left-sided diaphragmatic hernia is where's the position of the liver. If the liver's down, the diaphragmatic hernia is on the less severe side of the anatomic spectrum, and if the liver's up, it's on the more severe side. And right diaphragmatic hernia is in the middle, actually closer as a group to left liver up. So here's the left liver down, least severe, stomach down diaphragmatic hernia. Here's a baby that was born. This is the right lung. This is the left chest with intestines. Notice the tube that goes into the stomach goes into a stomach that's below the diaphragm. So this is a stomach down diaphragmatic hernia, the least severe. Stomach down are almost always liver down. So, and this baby should have a very good prognosis. Here's a good right lung, a good left upper kind of lung, some air down here. But over the next few days, that lung will expand. It'll never be as big as normal, but it'll be big enough. Here is a stomach up, but still liver down diaphragmatic hernia. Here is the right side. Notice the heart now is pushed pretty far over into the chest. That outline is the heart. Here's a little bit of this lung on the left side. And here's stuff in the chest. Intestine, and here's the stomach. See that tube that goes into the stomach goes down and up into the chest. So this is the next step in anatomic severity. And here is more severe. So this is a diaphragmatic hernia. Notice the heart's all the way up against the right chest. Notice the NG tube goes up. And notice this kind of solid area where there's no gas. That's a chunk of liver up in the chest. Now you can't see the liver on the chest x-ray most of the time. You need ultrasound or CT or something else to tell you where the liver is. But since most kids are diagnosed before they're born now, we generally know the position of the liver. Here's this baby after repair. You can see this flat kind of lung right there that doesn't fill much of the space, but it will expand somewhat over time. And then there's the insanely severe diaphragmatic hernia. That is left liver up, the baby's born, the right lung has almost no air in it. So the reason the baby's dual pain in the beginning is the lung really on the other side. Notice how lousy this lung looks. It should be gray to black, and it's white. And here on the other side, here's our NG tube and intestine, and we know from prenatal imaging that this is a liver up diaphragmatic hernia. The gas exchange, in other words, the work the lung is supposed to do to move oxygen into the blood and carbon dioxide out, is severely constrained in this baby. And I don't expect you to understand, have the depth of understanding for this, but this is the pH of the baby's blood at 1 hour of life. A baby should have a pH of 7.4. A sick baby might have one of 7.2. A really, really sick baby might have 7.0. Anything below 7.0 is considered highly severe. And this baby's as low as 6.64. His pH is greater than 130. And the oxygen level in his blood is 15. Most people would consider this baby non-salvageable. Remember this baby, we will see him at the end. Okay, that's diagnosing by anatomy. You can also measure severity by looking at the lung. When you look at the lung on the other side, so the lung-to-head ratio was developed by Dr. Michael Harrison and his group at the University of California, San Francisco. It's been around for a long time, and it's a way for someone to look at the lung on the other side and get an idea of how good the lung is on the other side. You can't generally see the lung on the affected side very well on prenatal imaging, which is why we look at the lung on the other side. And so lung-to-head ratio, I'm sure you've all heard something about this, just to put you in the ballpark. Greater than 1.4 is less severe, 1 to 1.4 is more severe, and less than 1 is very severe. And here in our series, you can see the average baby had an LHR 1.5, but of the ones that died, the average was 1.0. Of the ones that survived, it was higher. The purpose of this slide is just to let you know, less lung is worse, harder to take care of. These are averages and they don't speak for every baby. The other problem with LHR is you can go to 3 different sonographers, 3 different doctors, and get 3 different LHRs. So it is not a line in the sand. It's just another piece of data that we can use in getting an idea of how sick the baby is. The other thing about LHR is it goes up during gestation. The lung grows faster than the head, and therefore the number gets better. But the baby doesn't get better, the baby's the same. So ideally we measure LHR between 23 and 26 weeks, and when we measure after that, we make a correction to it so you can express the lung-to-head ratio observed value to what the expected value is. So as we get out of the 26-week window, we need to look more at that number. This is a significant number, but we should not define a baby's chance of survival solely by one piece of data. And then we can define, here's where the rubber meets the rubber meets the road. Up until this point, we're taking pictures of babies and predicting how they're going to do. We also take a picture of the cloud formation and tell you whether it's going to rain tomorrow or not. How often do we get that right? Probably most of the time, but not all the time. And it's important to recognize that our predictions of how a baby's going to do are helpful, but fundamentally imperfect. Here is physiology. So when the kid's born, how well did this heart and lung work together? It turns out that birth weight is related to severity. APGAR scores are related to severity. There's a predictive equation that can kind of tell you about severity. And we have found that the blood gas values at 1 hour of life, so the baby's born, resuscitated, has a reading tube put in, we do our best job for an hour, and then we check the blood gases, that those are very predictive of how sick this baby is going to be. And this is just to show you that birth weight, APGAR scores, predicted survival, first pH, first PCO2, and first PO2. These are the ones that die on average. These are the ones that survive, their average numbers. And these numbers over here are the p-value, or expressed another way, the likelihood that these numbers are different based on chance alone. And when the values are less than 0.05, they're considered significant, and when they're a lot less than 0.05, they're considered a lot more significant. So these numbers are very, very low, which shows there's a high correlation between the variables of severity for survival and not survival. Just to show you exactly what I'm telling you, that physiologic measures in the first hours of life accurately predict how sick a kid's going to be. Now, let's take anatomy and mix it with physiology and see that they're related. So we talked about left liver down diaphragmatic hernia, right diaphragmatic hernia, and left liver up diaphragmatic hernia. Well, those are the anatomic measures. These are the physiologic measures: birth weight, APGAR 1 minute, APGAR at 5 minutes, whether they needed ECMO, their predicted survival. And guess what? Left liver down kids tend to be bigger than right, this is grams, which tend to be bigger than left liver up kids. APGAR scores tend to be higher in a left liver down kid than a right, than a left liver up kid. See how those numbers go down as we go across here? The 5 minute APGAR, the risk of ECMO goes up as we go across this anatomic severity. 11% risk in a left liver down, 55% risk in a right, and 69% in left liver up. And the predicted survival goes down, showing you that physiology and anatomy are related in these kids, as I told you. So the most severe anatomic group is left liver up diaphragmatic hernia. That doesn't mean right can't be severe, it can, and it doesn't mean that an occasional left liver down kid can be severe. All of that is true, but on average, the left liver up kids are anatomically the worst. Here's a great picture that was done by the group at Children's Hospital Philadelphia. I really like this picture. This is the most severe anatomic subset. They have the worst pulmonary hypoplasia. And what is the survival of left liver up kids? It's 45% based on a meta-analysis. That means somebody looked at multiple published studies in the literature, added them all together, and came up with a 45% survival. And then a top children's hospital that I won't name also published a 45% survival. So that gives you a benchmark of what left liver up survival should be, or is. Not what it should be, what it is. So, that's a background about the measurements of severity in these kids. Nowadays, most kids are diagnosed before they're born, and then we talk to the families, and what should we tell them? Well, unfortunately, about 10% of the total kids have another major life-threatening anomaly. And by major, I mean a heart that has only one ventricle, or a big chromosomal problem, a big genetic problem, not so much a little genetic problem, but a big genetic problem, or multiple anomalies together. And those kids are a whole different group, and many times we choose not to be aggressive with those kids because we don't want to put them through something that they're unlikely to have a good outcome from. But that's a very personal decision that's made between the doctors and the parents looking at all the data together. Then the other 90% have really I'm going to call it isolated diaphragmatic hernia. It may not be completely isolated because maybe your kid's missing a kidney. Okay, well, that's important, but it's not going to affect the child's survival. Maybe the child has a hole in the heart between the two ventricles. That's important, but it's not going to have a major effect on survival. So when I talk about the 10% of major associated anomalies, I'm talking about that other anomaly is basically lethal on its own. And then you add diaphragmatic hernia to it, it's a pretty bad combination. All right, so now we're going to go and I'm going to teach you what I think are the fundamentals of care of kids in diaphragmatic hernia. Anybody play softball or baseball when they were growing up? I remember being told that those are the fundamentals. Throwing the ball, catching the ball, running the bases, hitting the ball. Those are the fundamentals of baseball. And so we're going to talk about the fundamentals of care in diaphragmatic hernia. These are the 5 major lessons we have learned over the last 360 patients. Lungs, repair, ECMO, risk stratification, and believe they can survive. All right, so this is the first paper we wrote. I arrived at the University of Florida in '92. We started treating babies with kinder, gentler ventilation. I didn't invent it. Dawn would like to tell you I invented it. I didn't. I was a copycat. The guy who invented this was a guy named Zhen Wang. He's a Chinese anesthesiologist who came from China to the United States. He couldn't get credentialed in anesthesia in the United States, but he could get credentialed as a neonatologist. So he worked as a neonatologist with an anesthesia background. And in the 80s, he started talking about taking kids with really bad lung disease, not diaphragmatic hernia, but really bad lung disease, and instead of turning the ventilator up, he worked on giving just enough ventilation to keep the kids alive. And he showed that the recovery potential of those kids far exceeded the kids where people kept cranking up the ventilator to try to make them better. And so he published a seminal article in 1985, published in Pediatrics, about kinder, gentler ventilation. Not in diaphragmatic hernia, but just as a concept. I trained at Columbia University. I was marinated in that environment, and I brought that concept to the University of Florida and started applying it to diaphragmatic hernia kids. Charlie Stoller was also doing that, really under the direction of Zhen Wang, and Jay Wilson at Boston started doing it as well. And we argue about who did it first, and it doesn't matter, but we started in August of 1992. There you go. So we started not overventilating these kids, but kinder, gentler ventilating them. We believe that hyperventilation and alkalosis, which was the standard of care, was bad. So we took that away, and we took care of 60 or so consecutive patients. This is how we treated them. They were born, we gave them light to moderate sedation. We put them on an SIV pressure-limited ventilator, not just a kinder, gentler ventilator. We used the lowest pressure to inflate the lungs we could that would cause adequate chest rise. We kept the pressures under 25 centimeters of water, which was our cut point between too much pressure and acceptable pressure. And we avoided overventilating or changing the pH of kids in order to try to affect their pulmonary vascular resistance. These numbers won't matter a lot to you, but we went for slightly higher than average CO2, medium PO2, but we tolerated a lot less if the babies weren't doing very well. So our goal is never to have a diaphragmatic hernia look perfect. Our goal is to have the baby look good enough. So we would push the support till they were just good enough. Because guess what? More support means more toxicity. And our goal was to preserve lung parenchyma. And here's what we found. We compared our babies with previous babies that had been overventilated. And over on this side, on the y-axis, is the pressure that was used to ventilate the kids. And on the x-axis here is time going by, 20 hours, 40 hours, 60 hours, 80 hours. And you can see time going by. And in 2 previous eras, you could see they used pressures above 25 centimeters of water. Here's one era, and here's another era where they really pushed the ventilator. And the pneumothorax rate, which is the rate that the lungs pop. Imagine being a baby with really small lungs and then they pop. That doesn't sound like a good combination. So here's the pneumothorax rate when they push the lungs hard. Here's the all well and good, but what happened to survival? Here's survival. This is percent survival here. This is time. Here's survival when you push the lungs hard, 20-some percent. Here's the survival when you push the lungs medium and then use ECMO afterwards, 50%. Here's the survival when you push the lungs less hard, still have ECMO as the backup. All of a sudden, survival rates were 80%. That was unheard of in 1992. And we couldn't have done this without ECMO. So I don't want you to think that none of these kids needed ECMO. Some of them did. But when they ended up on ECMO, their lungs weren't harmed, and we could get them through ECMO, and their lungs would be good afterwards. And the survival rose to a level that people didn't believe was possible. So we concluded that we must eliminate any iatrogenic lung injury. What does iatrogenic mean? It means we did it. Okay? We hurt the lungs by turning it up too high. So we have, as physicians, need to be careful not to turn the lung ventilator up too high. And we learned that the number of diaphragmatic hernias that survive is all about how well we take care of their lungs. As a result of that paper, we started getting referrals from around the country and around the world. I was at the University of Florida, now at Johns Hopkins. We're a high volume referral center. We have a high percentage of prenatally diagnosed and evaluated patients. And because of our referral basis, if you live in Seattle, for example, are you going to come all the way to Florida if your baby has a less severe diaphragmatic hernia? No, you're going to come because your doctor said your baby's going to die. And that's why you get on the internet and say, where else can I go? So our survival average, our severity average is significantly higher than the usual center because of the national referral. So as we go through, we'll talk a little bit about the distribution of severity in our patients. This is since we arrived at Johns Hopkins All Children's. That previous slide was University of Florida. These are the places kids have come from in the year and a half that we've been in St. Petersburg, Florida. Okay, treatment fundamental number 2. Repair the diaphragmatic hernia. It's very important, but it's also controversial. And we'll talk a little bit about the controversy. Okay, so here's the survival when the diaphragmatic hernia gets repaired in our hands. 90% survival if the diaphragmatic hernia gets repaired. Here's the survival if they don't get repaired. Okay, what does repair look like? So most of our repairs we do with an open incision. Some of these can be done thoracoscopically. That's a little bit of controversy, but we look at this as a life-threatening operation, and we want to do the very best we can. So in general, we do open procedures. We've done some thoracoscopic procedures, but most of the time we favor the open procedure. So this is an incision in a baby's abdomen here. We've pulled the stuff out of the chest, and we're looking up from here into the chest. We're looking at the hole in the diaphragm. So this is diaphragm in front. This is diaphragm on the medial side, which is the side towards the spine. And here's this hole. And it starts in the back to the side. So that's why the Bachtelek diaphragmatic hernia starts as a posterolateral defect. But it can be a small defect, a medium defect, a large defect, or the whole diaphragm. And when I say the whole diaphragm, I mean the diaphragm on that side, not the other side. We don't see the diaphragm on the other side. We stay out of the other chest. So here's the hole. It's not bad. I'd call that a small to medium. Here it is. We were able to close some of it with stitches, and then we still had a big enough hole that we had to put a patch in. And this is Gore-Tex, and I sewed it in with big ugly stitches. Here is a thoracoscopic view. So this is looking from the chest down. Someone's put a scope in, inflated air, and pushed the intestine down. And here is the diaphragm in front, and here's the diaphragm on the medial side, and here's the hole in the posterolateral side. There's the spleen, it's been pushed down. Here is an open repair with a big hole in the diaphragm. There's a little bit of diaphragm here, a little bit of diaphragm in front, but in this case, probably 85% of the diaphragm is now a piece of Gore-Tex. I think that's the same slide. Here is a view of the lung from the abdomen looking up into the chest. And it doesn't display as well there as it does here. It's beautiful here. but here is the lung. Here's this big open empty space where a lung should be. But you can see the lung fills maybe 20% of the chest. Here is heart. This is the side of the heart. This white thing is the phrenic nerve. The phrenic nerve goes to the diaphragm and makes it breathe. When there's not a lot of diaphragm, the phrenic nerve doesn't have a lot to do. And this is probably some esophagus here on this side. This is a little bit of diaphragm on the medial side, a little bit of diaphragm in front, and most of this diaphragm is missing. Like 97% is missing. Here is a baby we took care of very recently. This is the smallest lung I've ever seen in a chest cavity. I think that represents about 2 or 3% of a normal lung size. Okay, so I said repair was important. Well, why the heck wouldn't you repair the diaphragmatic hernia? Well, as we said, sometimes there are severe associated anomalies and the decision is made to not treat the baby aggressively. Those are often the reasons. But sometimes kids get their repair delayed. So they're born, they get ventilated, they get better for a while, and then they get worse, and then they get put on ECMO, and then the ECMO either doesn't go very well and they don't survive ECMO, or the decision is made to wait until the baby gets well and comes off of ECMO, and then the baby never gets well and comes off of ECMO, and those babies don't survive. And then the question is, well, could that baby that died on ECMO have survived if a different plan had occurred? And don't get me wrong, repairing a baby on ECMO is not an easy thing to do. You're doing a really big general surgery operation on a patient who's sometimes fluid overloaded and whose blood is completely anticoagulated by the ECMO machine. So many people don't have good experiences with doing those repairs, which is why many centers will not do repair until the child comes off of ECMO. Unfortunately, I believe those babies that die on ECMO unrepaired are potentially recoverable. So we have come up with a paradigm that allows us to treat all the kids, whether they come off of ECMO or not. All right. So what I'm bringing up is when you do the repair then becomes a big deal. So if we say we want to get the repair done, but we want to do it at the lowest risk time possible, and yet we have babies that have different risks because they're on different parts of the spectrum, how do we figure out when to do the repair? And is it as simple as one size fits all? Does everybody benefit from the same plan, or should the plan be different based on where we are on that severity scale? So in this paper, we looked at different repair timings related to ECMO based on severity. So what should you do with a left liver down kid? What should you do with a left liver up kid? What should you do with a right kid? And does it matter? I'm going to go through this very quickly because it's kind of confusing. But the key point that came up is for those kids that don't need ECMO, it doesn't seem to matter a whole lot when you do the repair. If you do it day 3 or day 4 or day 5 or day 6, I'm not a fan of waiting more than 6 days, but a paper written by the CDH study group shows that survival didn't seem to change much if you didn't need ECMO. The survival changes a lot if you do need ECMO. So we're going to talk about ECMO a little bit, but here's a basic ECMO thing for those of you that know about it. Tubes put in the baby's neck, down into the heart, drains blood, goes through a pump, goes through an oxygenator where we add oxygen and take out carbon dioxide and warm it back up and give it back to the baby. And you can do that all on the one side, the right side of the heart, that's called veno-venous, or you can put the cannula in the artery and pump the blood around through the artery, that's called veno-arterial. And who knows what the survival rate is on diaphragmatic hernia babies that go on ECMO, as reported by the Extracorporeal Life Support Organization. That's ELSO, that's the big ECMO group. So if a kid, whatever severity, ends up on ECMO, what's the chance they're going to survive? High, medium, low?
Low.
So nationally, according to ELSO, the survival of kids that go on ECMO with diaphragmatic hernia is 50%. Was that higher than you expected? Yeah. it's lower than we should be able to do. We should be able to do much better with 50%. It's been stuck at 50% for a couple of decades. We've made no progress on survival of diaphragmatic hernia kids on ECMO for the last 2 decades, based on that multi-center data. That doesn't mean there aren't centers that are getting better at it, but on average, it's not good. All right, so ECMO is important. So we asked the question, is it better if a kid needs ECMO, if they get repaired before ECMO, or if they arrive to ECMO unrepaired? And we looked at kids with liver down CDH, and just to cut to the chase, in our hands, the survival of liver down CDH is 99%. It didn't matter whether you repaired them before ECMO or repaired them after ECMO or during ECMO, they almost all survived. But we found that if we repaired them in the first 48 hours, the risk of ECMO was higher. Was that because we were selecting out the ones that were worse, or was it an effect of destabilizing a baby who was trying to become stable by doing an operation? We decided that kids with left liver down CDH would benefit from delay beyond 48 hours, so that's what we always do now. Kids with left liver down CDH get stabilized for at least 48 hours before they get repaired. If they end up on ECMO, they end up on ECMO, but not because we did anything. Then we looked at the left liver up kids. Remember, the left liver up kids are the kids that are dying at a 55% mortality. And what we found was, if we repaired them in the first 48 hours, the risk of ECMO wasn't changed. If we repaired them in the second 48 hours, the risk of ECMO wasn't changed. This is hard to see, but the survival when we repaired them first was between 90 and 100%. And the survival when we repaired them second, or if they went to ECMO unrepaired, was a lot less. It was statistically a lot less. So we felt that told us we needed to be more aggressive about the repair in the kids that are more severe. So the left liver up kids. It's almost counterintuitive, but the sicker they are, the more they need repair. Yet nationally, a lot of people are saying the sicker they are, the more they need stabilization. So this is one of the areas where we're running countercurrent to the rest of what other people are doing. Now this, you people aren't, or most of you aren't doctors. There might be a few scattered in here, I don't know. This slide sums up just about all my current thinking about this disease. So here's our diaphragmatic hernia spectrum of severity. Left diaphragmatic hernia, from less severe to more severe. The less severe has small bowel and colon in the chest. The medium severe has stomach and spleen. The more severe has liver, and the highest severity has a lot of liver. These patients on the less severe end have reactive pulmonary hypertension. That means if you piss them off, it'll get worse. And if you leave them alone, it'll get better. So the more you are on this end of the spectrum, leave them alone, let them stabilize, do their repair when their pulmonary hypertension is less. But on this end, guess what? The lungs are getting smaller and smaller and smaller and smaller as we go from that end to this end. Those patients have what's called fixed pulmonary hypertension. Their pulmonary hypertension is because their lungs are too small. And there's nothing about waiting that makes their small lungs any bigger. And so we think people talk about pulmonary hypertension, but they need to understand there are different components of that. Some that we can affect, others that it's a little harder to. These patients benefit from delay of repair to decrease risk of ECMO. These benefit from early repair so that guess what? They get repaired. Because we already established that repair is good. It's really sad when a baby with more severe CDH doesn't get repaired. So that's kind of the whole talk right here. Now, this is a study that we published a few years ago that honestly, we're not doing it quite this way anymore. But this study illustrates a point. These are left liver up kids. They're all left liver up, okay? And 20 went to ECMO unrepaired, and 22 got repaired and then needed ECMO. We looked at all these different numbers to see if these groups were the same. So their APGARs were roughly the same, their severity. We looked at every severity marker we could find and found out these two groups were essentially the same. But guess what? The survival of those who went to whereas the survival of those who went to ECMO repaired was 96%. So getting the repair done before ECMO appeared to be a really good thing. Why didn't those other kids survive? Because they had complications on ECMO and they didn't get repaired, or they got repaired late. So it's not so much the timing as it is you got to get the repair done is what we took from this. We tried to figure out who was going to need ECMO, and guess what? Your blood gases tell you your risk of ECMO, your pH tells you your risk of ECMO, the CO2 tells you your risk of ECMO, and the lung size informs the risk of ECMO. We put all these things together in fancy statistical equations. We can actually predict the risk of ECMO in a baby at 1 hour of life. We can figure out to a high degree of certainty based at 1 hour if that kid's going to need ECMO. It doesn't mean we do it at 1 hour. It's a prediction of what's going to come later, but it's a prediction that's right over 90% of the time. So we now use these equations to help us understand the severity of the kid. And notice what we've done. We're taking physiologic data, pH and PO2, and mixing it with lung size data. We're taking variables from 2 different places to help inform this. I think that's super cool. So what about ECMO? Kids go on ECMO and they get better at the same rate, different rates. Some centers will limit, you get 14 days and that's it. Does that make sense? Do the data support that? So we looked at our data of over 100 kids with diaphragmatic on ECMO to answer the question, at least in our experience, how do we figure out how long to do ECMO, and can we decide when patients are not going to get better? So we looked at time on ECMO, here's time on ECMO, to survival, okay? And we found that if you got off ECMO in the first 10 days, you had a very high survival. It makes sense. They got well quickly. But what if you're still on ECMO at 14 days? Well, in our hands, your survival is still 56% if you're still on ECMO at 14 days. Please understand, this isn't us deciding how long to treat. It's just seeing, we take patients off when they get better. So if you're still on ECMO at 2 weeks, it means you're not better yet. What's your chance of survival? Well, in our hands, it's still 56%. At 3 weeks, it's still 46%. At 4 weeks, it's still 43%. At 5 weeks on ECMO, still 1 out of 4 kids will survive, and then it drops off from there. We found that if babies had just 1 run of ECMO, they did a lot better than if they came off, got worse, and went back on ECMO. Second run ECMO saved some lives, but not as many as first run ECMO. We tried to see, can you figure out how long a kid will be on ECMO based on how sick they are? Yes, their APGAR scores relate to how long they need to get better. APGAR 1 minute, APGAR 5 minute, what is that? Predicted survival and lung-to-head ratio. Guess what? The sicker the babies are when they go on ECMO, the longer ECMO run they need. It's not one size fits all. Sicker kids need more time to get better. So limiting the time to, hey, you got however many days may not be the best. Now, please understand, these are based on our data. Other centers may have very poor survival after 2 weeks. So they may limit to 2 weeks because that's their result. What we're trying to show is what's achievable, what's the potential of these kids. These pretty color graphs show that if your lungs are bigger, LHR greater than 1, your ECMO run is shorter than if your LHR is less than 1. So bigger lungs get better quicker. Does ECMO improve survival? Did you know there's a big controversy as to whether ECMO improves survival? And I think it's because only 50% of kids on ECMO are surviving. So there are centers, mostly in Europe, that don't do much ECMO and report pretty good survival. And then there are centers in the US that also report good survival. And yet one group is using ECMO and the other's not. Can you compare those groups? Because it's hard to compare them and not everybody reports the same data, it's really hard to scientifically feel like you know if ECMO improves survival or not. I'm convinced that good ECMO done at the right time in patients that get repaired absolutely improves survival. But you have to do it on the right patients and you have to do it well. So it turns out that the more sick the baby is, and when I say sick, I'm talking about all those measures we had, lung size and APGAR scores and blood gases. The more sick they are, ECMO provides a survival advantage. The less sick they are, if a center's maybe not quite as good at keeping kids off ECMO and kids that are less severe go on, then the risks of ECMO start to overshadow the benefits. But at the end of the day, great ECMO, and not all ECMO is created equal, is central to great outcomes. And so our goal is to not do ECMO on kids that don't need it, and then to do really great ECMO on the kids that do need it. All right, so what lessons have I tried to inflict upon you in the last 40 minutes? Don't injure the lungs. Repair the diaphragmatic hernia. Use ECMO inclusively. What does this mean? It means offer it to everybody that has a chance to survive. We'll talk a little bit more about that. Risk stratified repair timing, that's what we were talking about, and when you operate on them. And this gets to, should we offer ECMO to everybody? So we looked at 270 patients we've taken care of, and we tried to ask the question, who were the worst 10%? So we've got the spectrum of 270 kids. Some are not too bad, some are medium, some are horrible bad. Who's the worst and how did they do? So what are the outcomes in the worst CDH patients? How do you ask that question? Well, or why do you ask that question? More severely affected diaphragmatic hernia babies may be terminated before they're born, or they may have treatment limited at birth because someone says, oh, I'm sorry, your baby's not going to survive. And people are doing their best when they make those determinations, but really, are they accurate? Here's our baby from before, pH of 6.64, PCO2 of 130, and a PO2 of 15. What, seriously now, what's this baby's chance of survival? I can almost guarantee you in 99 out of 100 children's hospitals, this baby would not be resuscitable. These numbers are so off the chart of severity that people would not offer it. So, we did a retrospective review of 268 consecutive diaphragmatic hernia patients. Just to be brutally honest, we report every baby that comes to our hospital with a heartbeat if they have a diaphragmatic hernia. We've had babies who delivered at home, were dead, were resuscitated, came in with CPR, lived a couple of hours with CPR. We reported them in our data. We've had babies that were transferred in with multiple cardiac arrests and arrived with brains that were not recoverable. We reported them in our data. Every baby that's treated in our hospital has one heartbeat, gets reported in our data. I know that because our results are good, people wonder, is he treating the sick patients and is he being totally honest? You make your own decision, but we treat everybody. Or at least we take on everybody. That's not to say we haven't had a baby where they had multiple anomalies and we talked to the family and we decided not to be aggressive. But guess what? We report that baby too. All right, let me go back. Sorry for the aside. In this 268 patients, 28 of them were excluded in our analysis because they had highly severe lethal associated anomalies. Remember I told you, bad chromosomes, bad hearts. But there they are, reported. And so there were 248 patients we treated to try to cure them. 172 were inborn. So we have a few babies that are outborn, and the majority are born in our hospital. Which group is more sick? The babies that are born someplace else, resuscitated and transferred in, or the babies that are born in your own institution? And when I say who's more sick, I mean if you had 100 of these and 100 of those, which group on average is more sick? The outborn or the inborn? You would think that. Why the outborn?
Because they badge them and
They aren't careful with them.
Yeah, so that's true. There are risks of less than optimal management of the other hospital. But the truth of the matter is the babies that are born in your own hospital are more sick. And the reason is, if you have a super sick kid that's born 2 hours away, he's going to die 2 hours away and never get to your hospital. If you have a super sick kid that's born someplace else where they're not very good at it, he's going to die at the other hospital, never make it to you. So the ones that make it to you from transfer have already had the worst of the worst filtered out. But the worst of the worst that delivers in your own hospital, you own them. They are there, and you can't explain them away. So if you look on average, if you want to find find the centers that are doing the best, look for the ones that have the biggest inborn group, and then see how they're doing. Because outborn changes the mix a lot. All right, so we wanted to know who the sickest were, so we looked at our inborn patients. We treated them aggressively survival, and those are the ones that make up this study. 172 inborn. So we decided who's the worst 10%. Well, what's 10% of 172? 17. So we tried to find the worst 17 to see how they did. We looked at all sorts of variables. APGARs, predicted survival, CO2 and pH, time to ECMO. We defined the worst, roughly 17, and we looked at their survival. 61%, 53%, 55%, 69%. Then we put all these things into an equation to help us take multiple variables to figure out who the worst 17 were. And so we created this fancy statistical equation to tell us without a doubt who were the worst 17, and here they are. Okay? 1 to 17. This is their birth weight, their APGAR score, their predicted survival, psi, their pH at 1 hour, their CO2 at 1 hour, their PO2 at 1 hour, whether they needed ECMO, whether they survived, time to discharge in months, and their respiratory support at discharge. This is the worst 10%. Here are the pHs at 1 hour. You guys aren't doctors, but I told you anything below 7 is super bad. So you can see how many of these are less than 7. These are CO2s. Anything above 80 is bad. Look how many of them are over 100. Here are the PO2s. How many of them needed ECMO? Almost all of them. Did any of them survive? Yes. Here are the ones that survived. Turned out almost half of them survived. What did they go home on? 100 cc's of nasal cannula, 400 cc's nasal cannula, 100 cc's nasal cannula. So about half the kids with worst diaphragmatic hernia can survive. How long were they in the hospital? 3 months, 3 months, 4 months, 3 months, 3.5 months. Most severe survival, 8 out of 17, 47%. But there's some more lessons in here. 3 of these babies were extremely premature. With extremely premature baby, we can't offer them ECMO. They're really just too small and too early for ECMO. Here's one at 28 weeks, weighed 1,000 grams. Here's one at 27 weeks that weighed 1,000 grams. Here's one at 33 weeks that weighed 1,200 grams. Okay? None of those babies were eligible for ECMO. And guess what? They all died. So then we asked another question. Of the worst 10% of kids that are eligible for ECMO, how do they do? So it turns out that's 164 kids. And so 10% of that would be 16. So we looked at the worst 16 that were eligible for ECMO. And you know what we found? 10 of them survived. The survival was 63% in the worst 10% that required ECMO. And again, they went home breathing spontaneously, breathing oxygen, no tracheostomies. And that's what I mean, the potential of these kids. Here we've looked under the rocks to find the worst 10% and found that almost 2/3 of them can survive. And how did they do with their lungs? None of our patients required tracheostomies or home ventilators. Here's our newborn from before with a pH of 6.64. Here he is after ECMO. It's not the world's prettiest x-ray, but this lung's inflated, heart's way over in the left chest, no tracheostomy, no endotracheal tube. He went home breathing on his own. So treatment fundamentals, don't injure the lungs, repair the hernia, use ECMO, even on the sickest ones, because they've got a chance. Risk stratify your treatment, believe the baby can survive. If people believe the baby isn't going to make it, they're going to be right. You have to believe the baby can survive to get the highest survival, and guess what? Mom should go to the best centers. All right, so what is the survival potential? What is survival potential in diaphragmatic hernia? This is 268 babies. 28 of them have lethal associated anomalies. We report them, we tell you who they are, and then we don't include them because it's not fair to include a baby with a diaphragmatic hernia in comparison to a baby with a diaphragmatic hernia and a single ventricle heart. It's a totally different level of severity. So, and when we're looking at centers and where to go and all of that, we're really trying to see how can we do with the babies that don't have the lethal 77 left liver up kids, 99% survival. 42 consecutive right CDH, 92% survival. 100 consecutive left liver up kids, 75% survival. That was when we were at 268 patients. Now we're at 360 patients. Since we've changed risk stratification for surgical repair in left liver up diaphragmatic hernia, left liver up diaphragmatic hernia is over 90%. So even the most severe patients can survive. Over 90% survival in left liver up diaphragmatic hernia, where the standard survival is 45%. These kids have untapped potential as we get better at learning how to take care of them. So, survival is only part of the battle, right? It's about how well they turn out. Here's a kid, he survived, but how is he? So the quantity of survival is all about how we take care of their lungs. But the quality of survival is absolutely about how well we take care of their brains. We have to think about these kids' brains every day at every step so that we have the best brain outcomes at the end. It's not easy getting these kids through. They are sick. They have low oxygen levels. They have high acid levels. They're on ECMO. But as we get better at every little piece of taking care of them, the survival goes up and the brain quality at discharge goes up. We have a comprehensive diaphragmatic hernia follow-up clinic where we look at lung function, heart function, reflux and nutrition. A whole nother thing to talk about is reflux and nutrition, but that would be another hour and a half. Musculoskeletal issues, kids are at risk for pectus excavatum, they're at risk of scoliosis. Their diaphragm integrity needs to be checked because there are a fair number of kids that are at risk of recurrent diaphragmatic hernia. Guess what? We can do that better as well. Recurrent rates do not have to be 35%, they can be 8%. And neurodevelopmental outcomes, all these things matter. Not all heads are abnormal, they're just at risk. Most of our kids have absolutely normal brains. 20 to 25% may have some demonstrable brain abnormality. All of our kids now, every one of them gets a brain MRI when they go home. We think it's our responsibility to look at how this brain looks. Everybody gets a neurodevelopmental exam when they go home, and everybody gets a brain MRI. MRI is extremely sensitive. It'll pick up things that may not be important, but we still want to know, at the end of the day, how did we do? So here's a baby. She was diagnosed, this is Kaya. She was left liver up diagnosed at 14 weeks. She had an LHR of 0.69. At birth, she was on VA ECMO within 4 hours. She was repaired at 3 days. She actually ended up on ECMO twice for a total of 29 days. And here's the brain at discharge. And there's a little bit extra fluid in front here, raising the question, is this brain a little bit smaller than it's supposed to be? Or, conversely, is the skull a little bit thicker than it should be? Either of those will cause a little extra fluid. But here she is at about 14 months here, Joy, something like that?
Probably.
She's just
Maybe a little less.
tremendous. She's meeting all of her milestones and is smart. Here's a recent one, prenatal CDH left liver up, less than 20% predicted lung volume. pH is less than 6.9 at 1 hour. We repaired him at 6 hours. He was 40% liver up. He was on ECMO before 24 hours, but he was discharged at 2 months of age. And this is Julian. Julian came from California. Here is another kid, very small, left liver up, lung volume less than 20%, pH less than 7 for 4 hours as we tried to resuscitate him. We put him on ECMO at 4 hours, repaired him the next day. So that's our new paradigm. I told you we used to try to figure out who to repair before and who not. Now we put them on, if they end up on ECMO, we do everything we can to keep them off of ECMO. But if they end up on ECMO, we repair them the next day. We don't ask a lot of questions, we just repair everybody the next day, so we don't have to worry about did somebody get repaired or not. And you know what? I'll tell you what, just do it. Okay, repaired the next day on ECMO, 45% of his liver up. He was off ECMO in 14 days, he had an insulin D2 of 1 month, he was home at 60 days. 60 days, how many weeks is that? 8 and a half? 60 days for a 45% liver up kid. Here's a family from the Pacific Northwest, a right CDH. They went all over the country. They went to 5 or 6 institutions trying to find what they thought was the best. So what are our current results? We've now treated roughly 35 consecutive diaphragmatic hernias at the Johns Hopkins All Children's Hospital. We've done, I would say 2/3 of our kids are left liver up. Probably 20% are right, and the remainder are left liver down. We take care of very few left liver down kids because we get sent to left liver up kids. One had a genitophalocele, one had a single ventricle. Remember how I told you a single ventricle? Not good, not good. Well, we feel like we've gotten good enough at the management of the other kids that we can take on a single ventricle kid. We've had kids with chromosome abnormalities, patients around the U.S. The average length of stay has been 6 to 8 weeks. I didn't tell you how many survived. Every one of them. We've now treated over 35 consecutive high-risk diaphragmatic hernia kids without a mortality. We're going to have a mortality. Not every kid is going to survive. But the point is, the potential of these kids to survive exceeds what we ever believed. And as we get better and better and better, there's a very bright future ahead for the outcomes of kids with diaphragmatic hernia. Nearly all diaphragmatic hernia kids have enough lung to survive. They have enough lung to thrive. So, I give this talk sometimes and people are like, yeah, that's nice, nod, good data. Do you believe it? Do you feel it? Because we had a couple of neonatologists that I talked with when I came to Johns Hopkins All Children's, and they heard the talk and they said, that's nice, that's nice, that's nice. And they didn't believe it. They didn't believe it. Now they are the biggest proponents of the team because they've experienced it and believed it. These kids have amazing potential. It's not easy. If I made it sound like it's easy, it's not. It takes consistency and dedication and following the principles and getting better every day in how we manage these kids. But it's possible. Now, you people represent a really important part of this diaphragmatic hernia thing, and that's that sense of community. Most of our families are all bound together now by this disease. They communicate through Facebook and Snapchat and a lot of things that I don't understand. And guess what? Cherubs is the first and the biggest and the most expansive and international. And so my hat's off to Dawn Ireland for all the work she has done. She has brought this charity, but really this mission from its infancy to where it is today. I mean, I really want to honor you for everything you've done. You've hung in through some really rough times, but look how many people are here. This is many more than previous years, and your website looks great, and the international focus, and it's a privilege for me to be a part of this and to work with Dawn and to work with Josh and Melanie and other people that I hope to meet later today. There are other groups starting to show up. Tiny Hero. Here's the Tiny Hero group back here, the Zolmans. So the Zolmans are equally passionate about what they do and making their contribution. For Hadley, the group in Atlanta, and I'm sure there are more and more and more. But the fact that Tiny Hero is here at the Cherubs Conference just shows how we can all work together to advance our shared mission. This is a reunion that we had at the University of Florida, and just showing you some of our families. They're very, very passionate, as you are very, very passionate. And this is our program. We have a whole program just about diaphragmatic hernia. We're actually going to build the first ever diaphragmatic hernia ICU, and hope to have that open in the next 6 months to a year. We provide very consistent oversight. We have a dedicated team that carries the baby through the full care. We're going to do 40 or more diaphragmatic hernias this year. I run the program. Joy Perkins is here. She's our coordinator. This is our team hospital. I don't want this to sound too much like an advertisement, but I do want to tell you that we are dedicated and we're available to help in any way that we can. And I want to thank everybody that's helped me get to where I am personally and our program where it is. These are all important people to me. People at the University of Florida, people at Johns Hopkins All Children, statistician that helped me a lot, my wife and my dogs. I have a couple of huskies. We live in Florida. There's no snow. We can't take them out to the snow to pull things. So we take them to Home Depot and strap them up to the cart, put some sand or concrete in there, and have them pull it around. problem is there are no brakes on the cart, so if they stop, it just runs into them. They have to keep moving. And I think that's it. Thank you for this privilege, and I'm happy to answer questions.
We need to keep the questions short because we have to keep on schedule because we have some staff members coming in from the university and a TV crew. So we have to keep on schedule for them. So if anyone has really short questions for Dr. Case, that would be.
Yes?
Do you have any study done or any data on the 10% that you said that has other lethal conditions, or is this only for the other 90?
So, we have reported who they are in our papers. The last paper that we published in the Annals of Surgery in 2013 went through exactly who those 28 patients were, so that people who read our paper knew who we were including and who we weren't. But we are pretty restrictive about what we call a lethal associated anomaly. It has to be a single ventricle or a chromosome that's really chromosomal problem that's very severe, or multiple anomalies. A lot of centers, so the diaphragmatic hernia study group has data, probably not very granular, meaning they don't know a lot about it. There are a lot of centers that don't operate on 20% of the kids or 25, and they consider them non-salvageable. So the data you're looking for is going to vary a lot by institution. What I consider lethal, I think everybody would consider lethal. But what somebody else considers lethal, I might not consider that lethal. But the only way we can know anything is to have people be very transparent about that, what they're reporting, which is why I tell you, this is a hypoplastic left heart, this is a double outlet right ventricle, this is a da-da-da-da, so people can look at what we're doing. A lot of centers just say, we excluded 50 patients. What they have, why did you exclude them? So, I'll share everything I know, but that's about it. But you want to go deeper? Is there?
No, I mean, is there any other institution that is doing that, or do you know of?
Well, I think all institutions have patients with severe and lethal associated anomalies. I think a lot of those babies get terminated, so they don't get born. The ones I'm reporting all were born. But I'm happy to talk with you more after this. Another question? Yes.
I talk a lot about survival, and I'm wondering, like, what age is that? I know that, is it just from when you repair it?
So when I talk about survival,
Yeah.
we're talking survival to discharge.
Okay.
So if they went home, they're counted as a survivor.
Okay.
It's not 30 days or 15 days or anything like that. They have to go home. Not get transferred to another hospital, they have to go home. So whenever I say survival, whenever I say